Okay, hello everyone. Thank you for joining us. So I just wanted to go through a few housekeeping rules before we get started. So we do welcome all questions on our presentations, but please wait till the end after the speaker has finished, and we'll have a Q&A period for each of the presentations going forward. If everyone could use either the chat or the Q&A, which is located on the right-hand side of your screen, you can just put your question in there and we'll take a look at them as soon as we can. And I'd ask you, you've probably noticed you can unmute yourself, but please stay on mute during all of the presentations. So we can get going then. Our next speaker is Maxime Lemerde, and he's going to be talking about pregnancy PBPK modeling, a very interesting topic. Thank you, Maxime.
Thank you very much, Elizabeth, and welcome everyone for this talk today. So as Elizabeth mentioned, the topic of today is pregnancy PBPK, but also why we think it is a necessary step towards safety and efficacy for drug approval for this very specific population. So as all of you know, so pregnancy lasts for 9 months that can be redivided in 3 trimesters. And during those times, both of the maternal physiology, but also the fetal physiology evolved quite a lot. From a healthy woman body, you will have some tissue composition differences and evolution. The body weight would change. Some of the tissue would change, but not all of them, to make space for the fetus to grow within the maternal body. And on the fetal side, so we start from one cell to go to, in the end, have 3.5 kilograms baby in average at delivery. So there are a lot of changes on both sides that need to be considered when we are giving a drug. And it really depends whether we want to give a drug to treat a specific disease that affects the mom or the fetus. For clinical development of drugs that could be targeted towards the pregnant population, there are a few guidance out there that have been published by the FDA or the EMA. And the first guidance was published in 2004 by the FDA. So this guidance is entitled Pharmacokinetics in Pregnancy, Study Design, Data Analysis, and Impact on Dosing and Labeling. And most of the guidance is really focused on when we should include pregnant women into the clinical trial, what should be the necessary steps towards safety, what kind of measure has to be taken, etc., etc. But one of the sentences that I have included in 2004 was to design your experimentation to have population PK modeling approaches, meaning that you could take less sample per woman and complement your clinical trial with a population PK analysis to fulfill your goals, to better understand how the drugs behave in the specific population, and trying to identify some covariates and so on. The FDA followed in 2006 and 2009 by 2 guidelines that are pretty much the same, except they don't mention any modeling approach. They only mention when to include pregnant women in clinical trial, what are the necessary precautions, and how to report those information. And then after roughly a 10 years gap into any guidance creation, in 2018, the FDA published a new grant entitled Pregnant Women, Scientific and Ethical Considerations for Inclusions in a Clinical Trial. So that guidance is pretty complete. It is taking all of the knowledge that have been published by those authorities over the last 20 years. But there is one sentence in this guidance that really struck me out, was PK studies including pregnant patients and then physical change during and after pregnancy that are critical for drug absorption and disposition may need to be considered in the model. And in this guidance, they basically defined how the PK information for pregnant women are currently obtained in real life. So to obtain clinical data and PK data in pregnant women population, you have two main options. You can either do clinical trial. So those are done in a very safe environment and very controlled. We know the drug, we know the co-medication. So there's a lot of control on the information, and we can really have great information. However, those trials are ethical only and if only the drugs would provide the direct benefits to either the mom or the fetus. So for example, if the mom is affected by cancer, there is a reason to maybe try a cancer therapy in that specific woman because there would be a clear benefit. You would not try a cancer drug in a woman that would be healthy because that would be unethical for both the mom and the fetus in a clinical trial setting. So if you think about it, there are actually a very small numbers of drugs that are administered to pregnant women. And just as a reminder, in average, a pregnant woman is taking between 4 and 5 APIs during the course of the pregnancy. But very few are tested in a clinical trial design. In most cases, what is performed by the industry are post-marketing studies where we look the pharmacovigilance data and we try to identify maybe which drugs have been taken by a pregnant population. Are there any side effects, major side effects? And that really raised a lot of safety concerns because basically we would see the effect only after a significant number of pregnant women would have them. So we are looking at the issue after it had happened. And that generates a lot of ethical limitations. So because of those concerns, other approaches are really necessary. And if I go back to that sentence that was published in 2018 by the FDA, that sentence includes physiological changes that are critical for drug absorption and disposition. And when we talk about physical changes, the better tool to really look at them and investigate their impact on the drug's behavior is really PBPK model. So over the last 2 years at Simulation Plus, we have developed a new PBPK model that can look at both the maternal difference in physiology at different stages of pregnancy. And that includes, for example, the weight gain during pregnancy, but also all of the physical changes that affect the renal function, the increase in GFR, for example, the increase in renal size, the impact on the GI tract, the impact on the cardiovascular system, the impact on body composition, and of course, also the impact on metabolism and some of the enzymes that are upregulated during pregnancy. So that PBPK model is basically the default PBPK model we had for women in GastroPlus, in which we included 2 new tissues, the uterus and the maternal placenta. So that's for the maternal side. From the fetal side, we created a new PBPK that has 4 compartments, the venous and arterial compartment, one single tissue named fetal, and then the fetal placenta. And the fetal PBPK model is connected to the maternal by 4 pathways that are listed here. I'm not going to read all of them, that have different impact on the transfer between the drug, of the transfer of the drug between the maternal to the fetal side at different stages of pregnancy. What we include from the fetal side, we have the hematocrit versus the gestational age, the age and the body weight of the fetus, the renal GFR versus gestational age, and many other characteristics. So the long story short is that model was developed with the intent to simulate both the maternal and fetal exposure at different stages of pregnancy. But before we could release that model, we went through a round of validation, and that's what I will be presenting in the next case studies. 2 validation cases, the first one for an API that is mostly eliminated by the kidney, and then for an API that is mostly eliminated by the liver. So first thing first, Let's have a look at an API that is eliminated purely by the kidney on the maternal side. And that API is an antibiotic, cefuroxime, which is very commonly used during delivery to avoid any infection and possible complications. The way we develop that model is following, the strategy we use is to first create and validate the model for a healthy population. And it doesn't matter whether those data were coming from men or female, because the PBPK model accounts for those differences already in the model. Once we had that baseline PBPK model validated, we could then try to simulate the PK in the postpartum data. So postpartum defines the time after the pregnancy, the few months after the pregnancy. And in that case, we had some data available in a postpartum population, so we could see whether or not we could simulate those data or if any model adjustments had to be made. Once potentially making those adjustments, we could then try to predict the maternal and fetal exposure in the pregnant populations. So that's what we did, and now I will show you the results. For the baseline PBPK model, we had data, plasma data in a men population receiving 3 different doses of cefuroxime as an IV administrations, so 0.25, 0.5, and 1 gram. As I've already mentioned, cefuroxime is only cleared by the kidney as a combination of renal filtrations and also active secretions. The active secretion is mediated by the O83 and MRP4 transporters. To capture that in the PBPK model, we change the tissue the tissue model for the kidney from perfusion to permeability limited in order to be able to implement those 2 transporters in the model. And then we fitted the Vmax. Once we had the Vmax fitted, we could then capture the data relatively well in healthy human populations. Then, moving on to the postpartum data, without making any adjustment to the model, we were able to capture the plasma exposure data, the plasma data in a female population at a postpartum state really well. However, the urinary excretions were slightly overestimated, so we refitted the Vmax for one of transporters, the MRP4. So a very small adjustment that was not really changing the plasma exposure, but only the urinary secretions. Once we've made that change, we were satisfied with the model, and then we could then move on to predict the PK in the pregnant population. So here on these slides, I'm showing the final results for maternal on the left in blue, so the plasma maternal, the fetal blood, and the amniotic fluid prediction overlaid with the data. And actually here I'm using the word prediction, but it's actually more like a fitting in a way that the very initial simulations were giving extremely good results on the prediction of the maternal side. So the maternal plasma was really well described. And from the fetal side, the AUCs were well described, but the Tmax of both fetal blood and amniotic fluid were not well described. So what we had to do, we had to change the placenta model once again from perfusion to permeability limited. And after making that change and optimizing the permeability parameter, we could then capture the data relatively well. But the question would be, why do we have to do that? And a very recent paper actually looked at the repartition of transporters in the placenta. And one of those transporters, or one family of those transporters, are the MRP, but especially the MRP4 transporters. And this efflux transporter goes against the transfer of the drug from the maternal side to the fetal side. So that's why we had to use a permeability limited tissue, and we had to fit the permeability somehow as a surrogate of that transporters. We could have included the transporter information directly in the placenta. However, the expression level at different stages of pregnancy is still unknown. So we had to find a surrogate to be able to capture the data relatively well. But we were lucky in that case because we had 3 other data sets for which we had both maternal plasma data and fetal blood cord data. And without making any other adjustment that simply changing the physiology to match the gestational age, so 39 GA or 25 GA, and the dose, this is what we could get in the final results. So we could describe the maternal side really well, but also the fetal blood concentration are really well described in that particular case as an external validation. So we are really happy in that case, but in a way, this is somehow like the easiest case study because the way the maternal kidney function is affected during pregnancy is pretty well understood. And we just had that mechanism to scale from non-pregnant to pregnant. In the second case study, I will be talking about an API that is purely eliminated by the liver, and that API is metronidazole. We followed exactly the same strategy, going from healthy subject, postpartum subject, and then the pregnancy prediction. In healthy subjects, and maybe what I should say first is that metronidazole is a drug that is metabolized by the cytochromes 3A4, 2A6, 2E1, and 1UGT. And we include those metabolism in the PBPK model. And after doing that, the model could very, very well describe the PK in healthy subject following both IV and PO administrations. So then we could move on to the postpartum subject. And this time, without making any adjustment, we had a very reasonable prediction of the plasma data in the postpartum populations. So in this particular case, we did not make any adjustments to the data or to the model, and we moved straight away to the pregnancy simulations. So here on this slide, you can see, and once again, pure predictions, no model adjustment of the maternal plasma concentration of metronidazole at different stages of pregnancy. So 11, 12, 24, and 36 gestational age. So basically the first, second, and third trimesters, as well as different dose. We had 0.25, 1 gram, and 0.5 BID for those 3 data sets. And if you look at all of this at the big picture, the model is doing a really good job at describing the maternal data at different stages of pregnancy. So that was really encouraging. And we could then move on to the next data set and see how the model would perform. And for the next data set, we had actually 3 studies in which we had both maternal plasma data and then some fetal tissue concentration. We had the fetal blood in one study, and then we had the fetal compartment and placenta data in the 2 other studies. Looking at the top row, so the maternal plasma concentrations, they're overall really well described. We could argue in the middle that we tend to overpredict most of the subjects, but there is only 1 data point per subject. And if we look at the 2 other studies, they are really well described. So probably there were the subject in this specific study were slightly, maybe the body weight was slightly different or something else is happening, but as a trend, we are really doing a great job at predicting the data. In this particular case, the placenta model didn't have to be changed, and without making any adjustment to the baseline physiology model, we're able to capture the fetal blood flow really well. Here, in the second study for fetal and placenta, we tend to overpredict those tissues, but we're also overpredicting on the maternal side. So our assumption is the overprediction is more linked to the maternal PBPK than the fetal PBPK, or the transfer between the maternal to the fetal, because the percentage of error between the maternal plasma is pretty similar to the fetal tissue and placenta tissue. So that was very encouraging as well. And we look at the last study, the placenta data point seems to be well described. And there is potentially a risk that we overpredict the fetal concentrations. However, and once again, this data point is only coming from 2 or 3 subjects. So we don't have really enough data. And this is the only data case studies in which we had fetal data to really conclude on the ability of the model to predict the fetal exposure during the first trimester. So just a quick summary. There are clear ethical and safety concerns that exist for the pregnant population when we talk about development of new drugs, or as well as generic drugs, actually. Pregnancy PBPK can really be a very important tool because it can predict both maternal and fetal PK and exposure. So that's really encouraging. We identify, case studies that in some case, postpartum data could be really interesting to calibrate the PBPK model. And finally, the placenta model structure probably has to be dependent on the molecule of interest, at least at this stage. When we will know more about transporter repartition within the placenta and transporter expression level at different stages of pregnancy, we are optimistic that the prediction we will be able to do will be better in the near future. So I would really like to acknowledge all of my colleagues, and especially Dr. Kei Tseko, with whom none of this project could have happened, and everyone else in the team for this project. Thank you very much, and I'm happy to take any questions that you may have.
Thank you, Maxine. That was excellent. It's a really valuable and interesting topic. Please, everyone, feel free to send questions in using the chat or Q&A. While we're waiting, I have one, Maxine. Could you provide any thoughts on use of postpartum data, and if there's any particular situation where that might be more necessary?
Yes, so we were pretty lucky that in most of our case studies, we had access to those data, but I think in a pretty significant case, we won't have access to those data in the real life applications because they are pretty difficult to get. And the mom has to come back to the hospital 2 or 3 months after delivery to do like a new PK studies. So those data are probably hard to get. I think in some cases, especially if the drug has a lot of variability, and if we know the variability of this API is pretty significant between subjects, it would make sense maybe to try to have access to those data. If you know the variability is pretty narrow, in that case, probably we could skip that phase and go more towards directly from healthy to pregnant population.
I was wondering how realistic animal models would be and if that would be helpful as a first step.
That's a great question. Most of the animal models are basically the rats. And based on my understanding of the science on this whole topic, the rat models, they have advantages, especially when you look at the potentially on the toxicology side of the effect. However, they are not really predictive of what could happen between, between the interspecies scaling is not doable or not easy to do at least. So what we are currently working on right now is to make the same effort for the maternal PBPK in rat. So we could also try to tackle that question to see, can we leverage by a combination of rat study and in silico studies to predict what could happen in the pregnant population in human.
So my other question would be, I was wondering about highly protein bound drugs. I was thinking of some of the anti-epileptics, which are important to continue giving sometimes in pregnant women. I just wondered if that had been explored at any point up to now, because certainly I think there's a
So
lot of
I am
pushing
not
by
aware of
Angie.
one of those particular drugs that would have been studies, but clearly there are some drugs that need to be continued. I mean, you mentioned the anti-epileptic. Drugs for some types of cancer must be continued. Some of the molecules for diabetes have to be continued during pregnancy. So it's always a balance between the mother health and what could be the impact of those 9 months of cutting the drugs off the system and the potential consequences on the fetal development. For highly bound proteins, what we know is that there is the albumin concentration in the plasma is affected by pregnancy. So that's something that could be that could be tested using those models to maybe at least trying to investigate what could be the impact on those change in the protein bond fractions at a different stage of pregnancy and see if there is any adjustment that need to be made to the dose for those patients.
So if anyone in the audience has any questions, again, please feel free to put it in the chat or the Q&A. So from your perspective, Maxine, what would be next steps that you'd like to do in terms of moving this forward?
Next steps, well, there are multiples. The one I've mentioned already is like trying to do the same efforts for rat and trying to connect both rat and human using in silico tools. Next step is more case studies to validate even more this model and these applications. And the next step, but the question will be, how do we validate those models, is to extend on the fetal PBPK side to not just have a fetal compartment tissue, but to have all of the organs as they develop. So for example, to have the fetal liver, the fetal kidney, the fetal brain. So then we could look at really maybe on a toxicology point of view, what is the exposure in the fetal brain of some APIs at different stages of pregnancy, and what could be the potential impact on brain development and CNS development. So there are lots of room for improvement. Based on my understanding, the FDA is also working on some of those projects. So it's really a field that is, I mean, it's out there, it's being used a lot. We are very hopeful that more models will be created and we can do more, and we can be used to better predict for the new drugs that are being developed, but also for the drugs that are already on the market, to better understand the situation, maybe look at different subpopulations. Are there any difference between an Asian population versus a Caucasian populations, et cetera, et cetera. Like, I really think sky is the limit in those cases. So there are many axes of research we could do.
Well, thank you, Maxine. I think we'll stop at this point. I don't have any other questions coming in, but thank you so much. This was really excellent. It's a great topic, and it certainly sounds like you have years of work ahead of you.
For sure. Thank you very much. Thank you all of you for joining.